Thanks, Tyler. Thanks, everyone. Good day and welcome to the webinar. We appreciate you joining us and look forward to the dialogue. As Tyler mentioned, this is one of our Visiting Scholars webinars in which we invite presentations from experts in a variety of healthcare-related domains to share their knowledge and expertise, and health insurance co-ops being that topic today. For those of us who grew up in ranching and farming communities, we're quite familiar with the role that co-ops play in distributing risk and expenses across families and members of the community in that co-op. Health insurance as a form of a community co-op is an emerging but not entirely new idea that resurfaced under the Affordable Care Act. Our visiting scholars today, Rick Schultz and David Napoli, will talk about the concepts of health insurance co-ops and the analytics that are required to support this unique form of risk management in healthcare. Rick has been the Vice President for the Kentucky Health Cooperative since November of 2012. He's responsible for the overall clinical care and quality management processes for the health plan. He was the Director of Quality Improvement for the Kentucky Spirit Health Plan prior to taking this current position. He was also the Senior Advisor for Retiree Healthcare of Kentucky Retirement Systems for over 6 years. He was responsible for the overall management of the health plans offered to the system's 40,000 Medicare-eligible retired members. Rick has previously worked as the Director of Population Management at Bluegrass Family Health and Director of Quality Management at Advantage Care, both regional managed care companies. David Napoli is Director of Performance Improvement and Strategic Analytics for Colorado Health Op. In this role, David is responsible for designing a framework for performance measurement and implementing business intelligence and analytic reporting systems for Colorado Health Op. David has 20 years of experience in quantitative development, advanced data visualization, risk adjustment methodologies, statistical testing and modeling, and analytic platform innovation. He has held the role of lead actuary and statistician, as well as Director of Corporate Analysis and Healthcare Economics for several managed care organizations, where he was responsible for the development of performance scorecards and dashboards for monitoring multiple metrics and identification of quality leaders. So we're really honored to have David and Rick with us today. Thank you so much. And with that, I will turn things over to Rick.
Thank you all. I know Tyler wanted to do several introductory questions to really get an idea of what our population was like, and I will turn that over to Tyler right now.
All right. In order to help our presenters have a better understanding of who's joined us today, we just have a few poll questions. We're going to go ahead and launch that first one now. The first question is, what part of the country are you in? The Northeast, Southeast, and so on. So I'll just leave this open for a few more seconds, give you a chance to vote, and then we'll share the results with everybody. All right, I'm going to close the poll in 5 seconds. Okay, now sharing the results, it looks like we've got a good portion from the Midwest and Southwest, with some from the North and Southeast. So that's a good cross-section. It's good to know. We've got another question, poll question here too, is do you have a contract with the co-op at this time? So let me get that poll question up for you. And you go ahead and answer that. All right, we'll go ahead and close that poll right now. And it looks like we've got about 18% of our audience said yes, they do have contracts with co-ops. That's very encouraging. And also, I've got a question for you as well. What is your knowledge level of co-ops? Is it minimal? Do you have a very high understanding of it? Maybe you're not quite sure and you're really excited to learn some more. So we'll leave this poll open for another few seconds and then share the results. All right, we're going to head to close that poll now. And in sharing the results, it looks like the majority have minimal or some. We do have 20% that their knowledge level is high. That makes sense connected with those individuals who, that 18% say they have a contract with co-op. So again, it looks like some things are trending in the right way, in the right direction. And we're really, really excited to be able to share this with you. Why don't you go ahead, Rick?
Okay, well, pending those results, I guess I'll go through this as far as what a co-op is and really how it originated. And the Kentucky Health Cooperative is a commercial-based product here in Kentucky. We are a not-for-profit, have the designation of a 501c29 tax-exempt organization. Specifically, I think that was designed for co-ops. The entity in and of itself must be a startup. That's one thing. Could not be in existence prior to, I believe, the middle of 2009. I think one of the components of a co-op that enticed me the most to come and work was that I think by the middle of 2015, our board at least 51% of our membership. And that election will take place towards the end of this year, beginning of next year. And I think that provides us a unique perspective, having members on our board.
Rick,
and the other aspect of
Rick, I apologize. We're getting some strange audio feedback from you. Just want to let everybody know that we do recognize that, and we're working on that right now. So
okay.
just to let you know that there's a little bit of the audio's breaking up a little bit.
No, okay. Well, I go to the next slide. As far as that goes, we do offer our products off exchange as well as through the exchange here in Kentucky. I think the main feature for co-ops is that any annual profits need to be funneled back into lowering premiums for current membership, improving quality, which is defined in the ACA extensively. Part of it also has to go back to repaying our loans, as well as helping establish our reserves, as well as a good financial groundwork for the plan to move forward. Next slide. Some additional parts of the funding is we receive startup loans, which was basically for establishing the workforce, the plan, and building the infrastructure to establish a health plan in this market. Those loans do have a repayment period that starts within 5 years of withdrawal and have a relatively low interest rate attached to it. Then there's also subsidy loans, which we are provided funds as we move through milestones that were drafted with approval of CMS. And as these milestones came to pass, we were required to submit documentation and forward drafts of policies and procedures, et cetera, to CMS in prior to receiving any of the subsidy loans. And those too need to be repaid, but that does come far out into the program, 15 years, again, at a relatively low interest rate. The benefit design, next slide, please. The benefit design for us in Kentucky was managed by the exchange and the Department of Insurance. They established what in Kentucky was called the Essential Health Benefit. It was an anthem plan that I believe 86% of members had chosen over the last year, and that was the basis for building your benefit design moving forward last year in preparation for offering those at open enrollment. There would be what would be considered reasonable out-of-pocket spending limits without any annual or lifetime maximum caps. There were specific other state-guided requirements for formularies that were to be offered and things. And quite honestly, the co-ops had there were different approaches by each state as far as how to build their essential health benefit. But as we move forward, we're beginning to work on our products for next year. all ready for offering, and we will look at how we can improve those benefits and be prepared for open enrollment of next year. So that's the basic short version of the Affordable Care Acts and co-ops part of that. And now I will go into Kentucky and how we are approaching the cooperative benefit plan and moving forward now that we have membership. And this is our first slide basically is a picture of Kentucky with our basketball and our horses and the relative other issues that we have out on the plate as far as from what we offer to the country. But next slide, please. We also have a large volume of uninsured people here in Kentucky, 640,000. Of those, 34% of those were at incomes below the federal poverty level, and another 34% of those earned up to 200% of the poverty level, which again is impacted by the Affordable Care Act. And then overall, 20% of Kentuckians were covered by some form of public insurance. So I think Kentucky will be presents an entirely different picture than what David will be presenting as far as Colorado goes. But that is the essence of the membership that we were trying to attract when we opened our doors. The next slide also presents really the status of our health in the state, and we are one of the bottom 5 in the overall health status. We ranked 49 in the Gallup Healthways Wellbeing Index, which was, I think, released in 2012. We have the highest smoking rate in the United States. We have the highest rate in preventable hospitalizations as well as cancer deaths. Number 6 in premature deaths. We have a large, over 20% of our population is obese by national standards, and we have chronic diseases related to cardiovascular health as well as diabetes. So going into this, the co-op knew that we were going to be presented with significant challenge as it came to managing whatever membership we did have. Now, we offered, next slide please, we offered the traditional 5 levels of plans that were mandated through our Department of Insurance and the exchange. We offered a platinum plan, gold, multiple silver plans, a bronze, and a catastrophic. One of our traditional models, we had an open network, which we continue to build on. I think the reason we chose an open network was our member-centric focus, the fact that we are going to be governed traditionally by our membership provided a backdrop for us to provide that open network. And I think the other significant choice was to do in-house medical management. Staff will be coordinating care through case management, disease management, as well as other programs that we will offer. I think one of the fundamental positive aspects that Kentucky brought us was that we were a state-based exchange, and it was a very functional-based exchange. I think they had a one time period of about 2 or 3 hours the first day we opened up for business as far as open enrollment goes, where there were problems, but we have received great feeds from the state. We anticipate meeting our pro forma membership volumes that we presented to CMS back in 2011 with our application, and I think one of the things that we are working with right now is just managing the volume of casework that we have. In Kentucky, there was a high-risk pool that was dissolved as of the end of last year, and all of those members became participants through the exchange. And from some of our initial numbers, it appears a good volume of those members have moved into the Kentucky Health Co-op, and I can recognize that just by the amount of continued care that we have been brought into as the members contacted us in the beginning of January. A lot of people were in the middle of treatment, and that brought about a great deal of activity in our medical management side. So we are pleased with our results and are busy at work with our members. I'm not sure if you're all aware of what the, next slide please, what constitutes an essential health benefit through the Affordable Care Act, but we offer ambulatory patient surgery, obviously, or services, obviously emergency and hospitalization, maternity and newborn care, mental health and substance abuse disorders, substance abuse being a new benefit that has not been offered in Kentucky through various plans. We have the prescription drug, rehabilitative and habilitative services, laboratory, obviously, preventive and wellness, and we have seen a uptick in that with the new membership we have inherited through the open enrollment process, and they're catching up on their screening services and those kinds of things. I will say, being number one in smoking, to date, we have not seen as many respiratory issues with our membership as we had anticipated. So I think, quite honestly, that is the biggest challenge we have, is to really establish a baseline. And from an informatics and analytics perspective, that is going to be our challenge moving forward, is trying to make predictions on what our utilization is going to be with a couple, 2-3 months worth of data. Will be about as onerous as it was last year trying to establish our rates for 2014. We also offer pediatric and oral and vision care. Next slide, please. Through the benefit design. And I think one of our key challenges has been with our case management and opportunities with member outreach is that we found that members that had never had insurance before were forced to navigate through what we felt was a medical delivery model that really often failed them for services. Being identified as self-pay and those kinds of things brought out difficult times for them to receive service in a delivery model that really wasn't really built for them. And I think now they feel much more at ease dealing with our membership. We have members calling in who want to fill out their health risk assessments and things, of which some of the literature we sent them, we asked them to do that. We've also had good activity on our nurse line that we offer for people who have questions off normal access to providers and such, and that has been a good occurrence. The one thing we're doing right now is, as our members who have been hospitalized transition to home settings or other settings in the delivery system here, is our clinical staff tries to educate them on what type of benefits they really do have access to. Traditionally, people don't read their COCs, certificate of coverages that they get, and really understand what their benefit is. And I think that's something that we are obligated to provide them, is really what type of services do they have access to, and where can they receive those. Next slide. As far as beginning the analytics process here, the co-op will use the information that we garner from the health risk assessments to begin basically establish baseline data for our membership. Again, it's self-reported data, which at times can be suspect, but at least it's more data than is available for these people traditionally. We are having interviews with staff or with members as they call in for the health risk assessments. We're identifying chronic diseases, and then we have planned member outreach as we get more and more data through the pharmacy process and medical claims review that we plan on trying to touch our membership to engage them in our various disease management programs in an effort to get them up to speed on their disease process and interventions that they can themselves be involved in. Next page. Care coordination is what we as well struggle with. Initially when we get our members post hospitalization, we try and aggressively make sure they follow up post-discharge with their providers. We try and teach and coach with them about medications. We currently have a population of anywhere from 40 to 50 people in the hospital every day out of our population, and it does keep us busy with this type of outreach. And we do encourage follow up through their providers and their provider staff, and are beginning to make plans for some outreach for specific patient populations. Once our enrollment periods are done, we're going to establish parts of the state where we have our larger member focus, so we can begin to do outreach models and set up screenings and things like that, where we can engage the membership in really taking control of their health. As far as the plan analytics go, we obviously pharmacy is the quickest turnaround of time as far as claims coming through our systems, and we analyze our pharmacy claims typically daily for high cost biologic drug regimens that members are on, and we focus on those as far as where we need to, next slide please, I'm sorry, Tyler, where we need to focus resources on. Concurrent review through our hospital stays also provides us with data, hospital days, those kinds of things, where members are coming from, where they're going to, so we can really look at the delivery model and where we need to focus more aggressive outreach for our provider networking. We're still building on that, and trying to really engage providers in active contract negotiations. That is probably the most important aspect as we move forward, is trying to get adequate networks. We chose open networks, and I believe that has been a key component of our success as we've gained members through the exchange. The HRAs, as I've said already, self-reported data may shed some light, but it's not something that we necessarily think will provide great deal of information. The claims model, we're beginning to process claims as our members have sought care through January, and we'll be able to start looking at some of that information, though it won't be trendable information at this point in our existence, but we are processing claims, which I think is a feat that all co-ops struggle with as far as trying to get functional at this point in time. But we have the data churning. We are looking at data as it becomes available on our members. We are building our infrastructure here. We're beginning our outreach. We're forming our baselines on our membership. As everyone knows, it's going to take us a good couple of years to really get any kind of active databases that we can really make any trending models on. And quite honestly, this population being an unknown, we really don't know, how much movement in and out due to income changes, what kind of membership churn we're really going to experience during the year because of the Medicaid parameters and those kinds of things. So it's really a growing time for us to really understand the processes by which a co-op is going to have to work. Next slide. And then finally, we have our goals for next year. Last month, we finalized and received federal loan approval for an expansion into West Virginia for 2015. So we're starting all over as far as implementation and milestones, et cetera, for getting entrenched in West Virginia. And that in and of itself will be another long-term commitment for the Kentucky Health Co-op. We are currently working on our rates for both Kentucky and beginning to establish some of those essential health benefit designs for the West Virginia model. But our goal basically is to maintain our member-centric approach for our medical management processes here and partner with our PBM for analytics as far as identifying any kind of trends in Kentucky, as well as trying to prepare an initial formulary for West Virginia. We do believe that the basic chronic disease problems that exist in Kentucky exist in West Virginia as well. So we hope to use the models that we've established here and ship those into that population in West Virginia. However, you know, we have our biggest processes there will be establishing a network and baseline plan designs moving forward. And that's where the co-op sits right now. And for the first 14 months I've been with the plan, it's been a very fast time, but we've been happy with the outcome. And I'm done, Tyler.
Great. This is Dale again here, guys. We've got a couple of questions. We're going to be pressed on time, so I don't know that we can answer all these, but let's address a couple while we're making the transition to David. What percentage of your 24,000 members were secured by members no longer in the high-risk pool? Also, did you enroll 24,000, or was this the state exchange total enrollment? And that's a question from Jack Hill.
Most of our enrollment came through the exchange. I'll be quite honest, the small group process has been problematic in the state, so I'd say probably 90 to 95% of our membership has come through the exchange. And the high-risk pool was simply, I really can't give you an idea on that. There were, from what I gleaned from the state, there were approximately 5,000 people in the high-risk pool. We worked on managing those members that were identified up front as far as care coordination goes, you know, those that had potential transplants online and those kinds of things. We got our case managers involved in those cares as they transitioned into the health plan. But I at this point in time, I really can't say what percentage of those members transitioned to us. Some days it feels like all of them did as far as our volume of services that we're providing at this point in time.
Okay, thanks, Rick. One more quick question, and then we'll transition to David. And this is from Michael Kovner. This is probably a little bit rhetorical, but there's also some sincerity here. Kaiser and Blue Cross Blue Shield are also nonprofit. What's the difference?
Well, I think, you know, from my perspective, you know, we don't answer to anybody but our members. So I think I can't speak to any other position on this other than our members will govern us, and so we're not really looking towards any other revenues other than being able to pay back our loan and provide better benefits for our members.
Yeah, that would be, having worked in nonprofits for virtually all my healthcare career, I would agree that seems to be the biggest difference. Okay, well, we've got other questions, but let's get to David's portion, and then we'll see what kind of time we have left. So, David?
Dale, thank you very much, and Rick, thank you very much for that very informative insights that you're able to provide, both on the Kentucky co-op as well as kind of the co-op program, if you will, in general. So what I am going to be speaking about here, I'll give a very brief introduction into whom Colorado Health Op is, as well as a somewhat unique approach that we are taking as far as population health analytics is concerned, and the focus on both members and then communities in general. So to give a little overview of Colorado Health Op, obviously just as Rick was saying, we were created through the Affordable Care Act. And in our instance, we did it through a partnership with the Rocky Mountain Farmers Union. It has been highlighted pretty much all throughout this discussion. They're definitely a member-focused organization. Board will eventually include some of our membership and will eventually be a majority member-run board. This is definitely done to bring the member voice into the organization, bring the member voice into the benefit design, and bring the member voice into healthcare as a whole. And not only then the focus on the membership, but we want to bring those community insights into the benefit design and into healthcare as well. And kind of the main drivers for our mission and our vision is really for Colorado Health Op to become the conduit for health promotion, both for our individual members, but again, throughout the communities within Colorado. The members and the communities definitely come first. That is our primary focus. And we want to be kind of the effective stewards then for all of the data, all the resources, and fostering this long-term relationship for our members and communities and the needs that each of them have. Now, how do we go about being that kind of effective stewards for all the members and the communities involved? It's really trying to introduce healthcare within these communities, as well as for members who may have only had kind of a cursory introduction to healthcare through, possibly acute events, through an ER, and that's really the only relationship to health that they know of, is waiting for almost a catastrophic event to occur and then hopefully getting it taken care of. We also want to foster that responsibility and foster and promote community health, as well as reaching out to all, not just the primary care providers, but really all providers, and establishing that integrated care throughout the state of Colorado and throughout all of these communities that we're hoping to establish and promote these health relationships. Now, Colorado exists as a state exchange, so I'm sure you're all familiar with healthcare.gov and kind of the whole wonderful rollout that occurred when that first started. So we are entirely separate from healthcare.gov. So our marketplace is Connect for Health Colorado, and Colorado Health Op is just one of the possible options that members can search through and choose from Connect for Health Colorado. Now, as Rick gave his introduction to what Kentucky looked like, I will do the same as well. And just what Rick was mentioning, how Kentucky is going to look different than Colorado, and it certainly does. So those same metrics that Rick presented, I'll present as well. And you can see from America's health rankings, Colorado was 8th out of all the states in 2013, and then the well-being index, only Hawaii was ranked higher than Colorado in 2012. And we also happen to have the lowest prevalence of obesity throughout the United States. So there are some definitely good health-related elements, as you can see right here by some of these metrics, but that doesn't mean that everything is perfect and rosy within the state. So this is also Colorado, and what's pictured here are the uninsured rates by health statistic region within the state. And as you can see from the different gradations, there is a significant variance depending on where you happen to be within the state. So the lowest one happens to be just in the southern area of the Denver metro region, where the uninsured rate is just a hair above 5%. So, and that's only 1 in 20 individuals within that region are uninsured. However, if you just happen to travel up over the divide and go towards the northwest corridor of the state, that same figure now jumps to almost 1 in 4. It's 24.8% in the HSR 11 range. So it's a significant difference, and significant differences within the health communities that are established between those two. Some other additional insights about Colorado. So we have about 740,000 that were uninsured in 2013, which is just over 14% of the population. And actually similar to Kentucky, 1 in 5 have public health insurance, so right around that 20% mark. Now, for the Connect for Health Colorado enrollment, it is at approximately 70,000 so far have enrolled. And Colorado Health Op, as our own individual group, we have close to an 11% market share so far. So we're pretty happy with where our membership is taking us at this point. Now, another piece we like to look at besides just kind of the uninsured range is really looking at the health literacy of those members within the state and looking at integrated care, especially between physical care and mental health care. And what really sticks out here is that there is this lack of health literacy and really understanding that there should be this integrated care, that over half of the people surveyed in this instance did not pursue or utilize mental health services because they didn't think it would be covered. That's something that needs to change, and that integration of physical care and mental care needs to occur at the same point in time. And members need to understand that they go hand in hand. So this is obviously an outreach, this is a provider issue, member issue, community issue. This is just a health promotion and health education issue that, as the co-op, we feel that we can be then that conduit between all parties involved to help mitigate this value. So how are we going to go about and do that? This is where our focus starts to differ from a population health perspective. So if you're not familiar with the Folsom Report, and obviously everyone is pretty much online, otherwise you're not going to be seeing this. So I could give you a little bit of time, open up another window, and you can Google the Folsom Report. What's shocking about this is the Folsom Report was put out in 1967. That's the original one. The one that you see here on the display is kind of the, we'll call it the sequel to it. So this came out in 2012. This kind of revisited what the recommendations were for the Folsom Report and where we were. And as far as progress, it was unfortunately minimal at best. And one of the big recommendations out of the Folsom Report is really around what they determined was these communities of solutions. So it is trying to bring together all possible sources to improve health. And it really goes beyond what you would standardly think of as healthcare solutions, which is totally and only residing within the medical community. So their communities of solutions approach really went well beyond the standard boundaries. And what's interesting on this was, coupled with this 2012 one, and it just came out last month, was the Robert Wood Johnson Foundation and their Commission to Build a Healthy America released their recommendations, which almost mirror what was presented within the 1967 Folsom Report, as well as the 2012 kind of revisit of this. So I would highly suggest, if you're not familiar with either of those sources, to go out and read on them. Highly impactful, and I said this is the approach that we are using to not only reach out for members, but to reach out to the community as a whole and really establish these relationships. So what makes up these communities of solution? I call it actually three kind of sheds that encapsulate this whole idea. I'll discuss two of them right now. The third one, and I'll just do the slow reveal on it as we go along, and you'll see kind of where that is leading. So the main two items that make up this community of solution is really determining what is the problem, where it exists, whom does it impact. I mean, that's that problem shed, and it really needs to be completely defined. And I feel some of the current population health approaches only capture a portion of that shed. They really only are looking in the dusty corner, and not every aspect of the shed is explored. The other important aspect is now that resources. So this is the asset sheds. What are those local organizations within these communities that can help identify what the health problems are and then act upon it? What are some of the data needs that can help feed all of the assets and resources that you're bringing on, and what are those local solutions that can be developed for the problems that are really being identified? And I feel the co-ops are in a really good position to be able to gather all of the insights and information around these sheds and get them moving forward. So before I dive into kind of the analytic approach on this, let me present a little story here, and you'll see how this story plays into what the analytic needs are. So I'd like to introduce you here to Bill. He happens to live in downtown Denver in a small apartment. He's lived there for a number of years. He's had a number of jobs. He's been a truck driver. He's done carpentry work. He's even been a cab driver. He's approaching 60 years old, but Bill is what is known as a hotspot. You may be familiar with that term. If not, over the next couple of slides, you'll be introduced to what that is. So Bill has had, unfortunately, a number of hospitalizations over the past year. He's actually been in the hospital 7 times, heart failure 3 times. He's a type 2 diabetic. He's been in the hospital twice because of that, and multiple other reasons. He's also been introduced to the healthcare kind of system through the ER 9 times over the past year. Again, part of that due to his uncontrolled diabetes, his chest pain related to the heart failure issues, amongst some other issues as well. Now, through all those visits, especially through the ER visits, Bill was identified as called the super utilizer. That's that hot spot. So obviously identified as that high utilizer, he was identified for a special program, really kind of this aggressive healthcare follow-up to really help Bill get better control of his acute health issues at the time. And those steps actually helped work out. Bill started losing weight. He lost 30 pounds. He now sees his primary care physician about every 3 weeks. His blood sugar declined. It was hovering around 12. It's now just under 8. And besides just seeing his primary care physician, he actually is now seeing a counselor to help with the mental health issues. So he actually sees him every several months that helps with his depression over all of his health conditions, and he's getting better on that. His medications he now takes right pretty much out of habit, and now he's starting to eat better. His utilization is now dropping. His costs are plummeting. So this kind of hotspotter, unfortunately, is not all that uncommon. I mean, you could pretty much find them within just about any community that you look. And as you can see here, those type of hotspotters, from a financial perspective, both on the healthcare system as well as their own personal financial, they have a significant impact. And it's not something to be taken lightly. But this is only part of the story. It goes much, much deeper. So if we really look at the next layer, this is looking at where Bill happens to live. And it's an area in the Denver metro area called 5 Points. It happens to be a poorly maintained park just a few blocks away from where he lives. That's about it for resources in the area. There happens to be a couple churches nearby, but they're mainly shelters for the homeless in the area. The medical facility that he can go to is actually several bus stops away, so it's not right nearby. And most of the development that exists in this area is surface parking. There's not really any established businesses or communities or places to eat or places to shop. There's places to park and then go elsewhere for it. As far as pedestrian traffic, it only exists to walk to and fro the parked cars. It happens to be an area that you would describe as lighted. But that blight isn't really the only area that you see these type of health issues existing. They exist within the suburbs and gated communities as well, where people pretty much live almost in isolation, where there's lack of kind of that integrated care that you hope for, and there's really poor collaboration between the health of the communities and the public health systems, between even the schools within the area. So it's not just location, and it's not always money or the lack thereof that you can help to identify these type of issues. So it really goes beyond hotspotting. Hotspotting is an important issue, and those members need the care that they receive, and they need to be focused on and assisted. But population health and the analytics behind it need to go beyond just the hotspotters. Find out what the real underlying problem is, and that's a term it's called cold spotting. So it is trying to identify these communities, these areas, these regions, where the social determinants of health, the support for health, access to care have all broken down. So this is now the focus where the analytics should be beyond just the hotspotters. The shed is much bigger than just what the hotspotters that you can see. Now we focus on the assets. So we have the problem really defined. What are the assets involved in this? Well, you have the usual suspects. The hospitals in the area, all the providers, community care clinics as well, public health resources. But again, as I said, you need to look at much beyond the standard healthcare community. So the unusual suspects that need to be brought in, the schools, the churches, local businesses, local clubs and community organizations, and absolutely the members and patient base needs to be brought in, and I think that's where the co-op can shine. We bring the member voice to the table, first and foremost. Now that we have those two sheds defined, let's start going on to what the third one is. So how do we develop all the data and analytics? So some of the existing plans and existing approaches within population health, they're all built upon multiple layers. They have these legacy systems in place, tons of data structures, and it's just hard to really be able to weave around and get to know where you're supposed to go with the data and these types of complex relationships. Different formats, is inconsistent rules applied. The analytics that come out is generally unverifiable. This is not really a environment that would assist in communities of solutions types of approaches, which perhaps is why it hasn't been used before. Co-ops give you a much different picture. As we start approaching this kind of analytic environment, we are truly a clean slate to start with. We're just establishing these data relationships. The technology that we can use to apply for this is really at our choosing at this point. We can pick and choose what we know would work best for everyone involved, for the members, for the communities, for the providers, to become this conduit of insights and information involved. So it's not totally uncharted, but it definitely is a refreshing type of look at this point. And we have this open road in front of us that we can now explore for these communities of solution. So what does the data be involved for this? Everyone's heard the term big data. It comes up almost on a daily basis in one way, shape, or form. At times it's thrown around that big data will be able to solve every problem. We realize that that isn't entirely true, and understand that most people, if they sat down about it and thought about it, they would know that is the case. But what seems to be the approach most of the time is utilizing big data as the sole approach to population health, and that using big data within population health is going to allow these solutions to come up that'll just thread the needle on what the issue is at hand, and it's going to give you the total solution for that population metric that you happen to be looking at. And again, taking that big data approach and trying to thread the needle is only going to give you part of the solution. It only looks at part of the problem and asset sheds that I described previously. Especially if you're doing this from a predictive analytics approach, it's only going to be partly successful. Yeah, you're going to identify potentially those hot spotters or those soon-to-be hot spotters, but it doesn't get the entire answer that is required to help not only the member but the community that they live in, and all members, all community members involved at that point. So if I had to throw a term around the data that we'd be using in this instance, I wouldn't call it big data. I'd call it more wide data. So again, this is more than just administrative type of data that you get. It goes beyond what you would picture as standard EMR data. The data goes well beyond what most analytic data warehouses are even defined to encompass. But it goes even beyond this. I wouldn't even really call it wide data. So what really matters, it needs to be meaningful data. It needs to be meaning for the members, for the patients. It needs to be meaningful for the providers. It needs to be meaningful for the community leaders, for everyone involved. Once you get that meaning for and from everyone involved, that's when you can have these lasting impacts. And it allows for ongoing needs assessment to be done. It allows for the evaluation to be done from everyone's perspective. It allows for that continuous quality improvement. And I think one of the biggest elements that a meaningful data approach brings is it shifts the focus away from looking at the never events. You know, you should never have someone showing up in the ER 7 times over a year, or you should never have someone readmitted within, that 30-day time period. It shifts the focus away from that to the focus on the always events, to what is really important, what should always be happening to keep the members and the communities and promote the health of those individuals and the individuals living in those communities. So what are those data elements that we use for this? And I believe the co-op can help kind of be the bridge to all these data elements for the members and for the communities. This is not obviously an all-encompassing list of items that we have here. You'll see some of the standard items on here. They don't go away. So administrative claims are there, health risk assessment data and related biometrics. But there are things that go beyond it. So the EMRs, I view that much more so than what standard EMRs currently contain. I view this EMR data as kind of the new vital signs, that EMRs need to include non-medical indicators of health. They should have data on the members that what issues they are having maybe in their home life and in their community life, so you could start identifying the underlying issues within those communities to help develop the communities of solution. Then there's survey data, the MEPS and BRFIS data. You're getting into kind of the behavioral aspects of it. And then from the asset perspective, always being that health is local piece, you have the Colorado Health Access Survey, which brings more insights, and that was kind of that insight into the uninsured population throughout the state. There's more insights that are available in that can be used to help develop the community solution, as well as the Colorado All-Payer Claims Database. This really starts getting into looking at what health access and what health integration either does or does not exist within the state. Once we have this bridge to all of this data and we want to start developing the insights, now this gets back to the cold spotting piece. This is the analytic approach to population health, where using all of these data elements, you start doing what's called cluster analytics on this. And those clusters help identify what those communities or solutions are. And those clusters will all have similar underlying behaviors and similar expected health trajectories based on what is or unfortunately may not be available within those communities, within those clusters that have been identified. That becomes the third shed. So those clusters are now the summary of health experience data, which happens to fit nicely with the acronym for SHED. That's the analytic approach that I believe that co-ops can now offer and really become that bridge to insights and sharing for community solution and analytics throughout, and in our case, without the state of Colorado. So here's some additional information on me. I could definitely continue this conversation here, as well as you see my lovely Twitter handle. Let's see if someone can maybe even guess how I even got that name, but I'm always active on that one as well, so we can continue this conversation even well beyond what this webinar is structured for.
Great. Thank you, David. Very well done. Tyler, you just put up another slide about upcoming webinars, and we'll be at HIMSS. Health Catalyst will be at HIMSS. Great. We are running a little bit out of time, but let's try to take a few questions. We still have 76 folks online. One of the questions from Patrick Lester was, do essential benefits include imaging? And that sounds like that would be a question for both panelists. Essential health benefits. I'm pretty sure it does include imaging. Is that correct, Rick?
Yes.
Yes, it is.
Very much so.
Yeah, that's what I thought. I have a question here too. That's I've been trying to figure out how you, with a relatively small population set, how do you manage the analytics of that small N in a typical actuarial setting, or do you really need to take a typical actuarial approach to these co-ops? So, Rick, you first.
Well, I think, what you're almost forced to is work with your actuaries and see what kind of databases and what kind of populations they have that exist, similar to yours, because you simply just don't have the data to look at, for your population, and we won't for months as far as that goes. So I think we're forced to look at pools of data that have been collected, by the actuaries, and then make assumptions coming out of that.
Great. David, comments on that?
Yeah, absolutely. So that's that cluster analytics approach that I mentioned. It leverages then whatever your kind of full N to be able to tease out then the metrics and characteristics within each of those clusters, within each of those communities that are the important, the meaningful ones to then focus on. So you actually don't need that sizable of a data set in order to start getting those insights and being able to act upon them. So it's very, very analytically favorable, as well as then member and community favorable as well.
Great. Another question from Patrick Lester. How does this integrate with existing programs such as Peak Vista in Colorado Springs? Sounds like that's a question for David.
Yeah, correct. So it obviously fits in extremely well. So we are already working with the Colorado Health Neighborhoods, which is one that's, for an example of a community of solution-based approach that already exists. And so those type of already established community-based relationships, and those go hand in hand with this type of approach. So we're already starting those type of discussions to get them and foster them throughout the state.
Great.
Right, Dale, we are at,
question.
I was just going to say we are at the top of the hour. We do have time for one more question.
Okay. The final question is about the politics of this, right? You can't separate the politics of healthcare reform, unfortunately. That's just the nature of the beast. And co-ops, I've always personally been a big fan of co-ops because I think they balance community aspirations with a form of socialized medicine, actually. Communities taking care of themselves. But I noticed in the latest version of the Affordable Care Act and the negotiations that are occurring that two things happened that I thought were kind of troubling. One is co-ops are restricted from large employer membership, and you don't have the ability to spend your federal loan money on marketing. Any comments from either one of you on those two issues? David, you first.
Sure. So from the marketing perspective, I mean, that is absolutely true. We can't utilize any of the federal loans to do our marketing. So we have essentially reached out for grants within the Colorado kind of health community to be able to help promote ourselves, as well as taking a very ground roots approach. Again, this is the community's the solution perspective of getting out on foot within these communities to not only then let them know of what the co-op is and why we exist, but it begins to establish that discussion point and that dialogue for the community of solution once that is in place.
Rick, your thoughts?
Well, I agree. I think we were behind the 8 ball as far as not being able to utilize any of our funding from CMS for marketing. So we pursued outside funding sources as well and obtained money and in a short-term loan basically, and we'll be paying that back early 2014, but made great inroads with the amount of money we did get to get an aggressive plan out there late in the game, because again, this, the whole process was through an approval mechanism through CMS to get the funding. So it was difficult. We obtained it. We thought it was productive for us at this point in time. But now moving forward, that we're receiving premium dollars, that allows us some opportunity to do our own marketing now.
Great. Okay, one last comment. The Jack Hill notes here that might be a correction to what I just said, and that is co-ops can do large group insured arrangements, and CMS has approved along with DOI these arrangements. So that's news to me. That's good news. I'll spend some time looking into that. Thank you, Jack. All right, I think we're done. Thank you both so much.